I'm Spencer King here at the ESC looking at the Tuesday highlights with Fred Beauvais. Fred, as you know, is editor of Accel. Fred, we've got a lot of heart failure trials today, and I think they're quite interesting. We should chat about them a minute. The ATOMIC acute heart failure trial. What was your take on that one?
Well, ATOMIC was testing a new drug. It's called ATOMIC-AHF.
Easy for you to say.
Yeah, well, not so easy for me to say. But at any rate, it's a drug that's kind of in the class of inotropes that act on myosin to improve its contractility. The original study, it's a phase 2 trial, was looking at dyspnea as an outcome using a subjective Likert scale of 3 different doses of the drug. The key, I think, is that it did not show a positive endpoint. I will say that there was improvement in the dyspnea score in both the control and the treatment group, in the high-dose treatment group. And I think the investigators thought, even though the differences in the two were not significant, that they both had a significant reduction in the dyspnea score. So that I think it gave them some incentive to move forward. There were a couple of signals, maybe a little better 30-day outcome, but not enough data because it was not their primary endpoint. So the conclusion of the study is it looks like a promising drug. It, at least in animal studies, did not show the problems with arrhythmias and other things that like milrinone has shown, or amrinone, the older drugs. So I think it gives them some incentive to move forward with some other continuing trials in this new drug.
Yeah, and another direction in heart failure, of course, is resynchronization therapy. And we've got a couple of trials that took a look at this. One is extension of the MADIT-CRT trial, first of all, and that trial looked at patients who did have prolonged QRS duration or bundle branch block. What did we learn there?
Well, this MADIT trial was a follow-on of the original MADIT trial in the class 2 heart failure patients. That is, the patients did not have the original clinical indications for CRT. Their data confirmed the original findings that at 6 years, there's still a positive outcome in the CRT-treated patients with class 2 heart failure. Improved ejection fraction, improved left ventricular size, and improved clinical symptoms in this class 2 group from CRT. And these were patients with wide QRS, but again, without the class 3, class 4 symptoms that were the original indication. So I think the message here is that the class 2 patients getting CRT for a wide QRS are seeing long-term benefit.
And we have other patients who don't have a wide QRS, but there's been a great interest in trying to figure out who would be helped, and the use of echo to judge the CRT was investigated in the EchoCRT trial. That turned out very interesting.
Well, I think it does provide some interesting insight. The first point is that the narrow QRS patients did not benefit from CRT. I think that we think we had that information before, but this confirms very strongly that the echo data is not enough to show benefit from CRT. The interesting piece of the study was the mortality was actually higher in the patients that got the CRT who had a narrow QRS. So I think it really nails down the fact that we should not be doing CRT in patients with narrow QRS.
Yeah, so this is quite important information to get out there. Now, one of the trials presented today was very interesting to you, I expect, you being an athlete and interested in this, but the one called Tour de France. Tour de France trial. What was that all about?
Well, I think, again, being a runner and a biker, I think this is very, very interesting to the people that do exercise. But what the French investigators did was they went back to the French registry. The French health system records the data on patients. They got every French participant in the Tour de France starting in 1947 and followed every one of them up to 2012, looking at their long-term outcome, their cardiovascular disease incidence, cancer disease incidence, and a number of other things. The interesting information was, number one, there was no increase in cardiovascular mortality in this group. In fact, it was lower, significantly lower, with a 0.6 hazard ratio. Likewise with cancer, the one thing that was higher in this group was accident-related deaths, but this is a younger population. We already know that happens. And they calculated that this group of athletes, very, very high-intensity trained athletes, actually extended their life expectancy by 6 years. Now, in the context of what we do today with all of our new sensitive tests, EKG, troponin, MRIs, echo, we're getting a lot of signals from our data that suggests there is heart damage from this level of exercise. I think this study, at least on the face of a large population base, is suggesting that even though we find these early findings that may not last or that may be incidental, are not causing long-term mortality in these high-intensity athletes.
A lot of confounders there. It's going to be difficult to work out. There's another trial that was a patient-level look at 3 trials in the Champion series. That is Cangalore. Cangalore, a drug we don't have yet available in the United States, but a very interesting drug for antiplatelet therapy. And this particular trial, this patient-level analysis looked at all the subsets to see who might benefit. It turned out, as expected, that there was a benefit, a small benefit, in ischemic endpoints across the board, every subset you could think of. And there was increased bleeding, but the increased bleeding was only in minor bleeding. There was not an increase in serious or life-threatening bleeding. So this is additional information about a drug that probably has very important benefit in some subsets, and our challenge is going to be to figure out, if we get this drug approved, what subsets we should really use it in.
Yeah, a couple things to point out. Number one, it's an IV drug, so
Yep.
if you can't give somebody oral antiplatelets, they've got nausea or whatever, that you can use this as an IV antiplatelet drug. And the second is it's got a short duration of action, so it can quickly disappear if you do have to send a patient to surgery.
Yeah, for quick action and quick offset, this would be ideal if we can figure out who we need it for. Enjoyed visiting with you. Thanks a lot, and we'll see you later on for Cardiosaurus. Thank you very much.